going to give one more minute, and then we'll get rolling. Okay, everyone, it's 11:02 by my clock, and I'm going to say a few things to get us rolling, and then I'll turn it over to Josh. First thing I want to ask everyone is to please mute yourself so that we don't have any background noise, we don't have any interruptions that distract or that slow us down. So if you could do that, please. I have given, I think, everyone permission to record, so that'll give you the opportunity both to take notes at a little less furious pace, and to have access to the video. Joe Kaspermeyer and Skip Dara, who are also from the ASU Media Relations team, are on this with us, and should you not get the recording or find that you thought you did and you don't, you can contact us afterwards and we'll be glad to provide it to you. You're going to be hearing from someone who I think most of you know, Dr. Joshua LeBaire, from our Biodesign Institute. He's going to share with you some data trends and other information that it represents part of what the university is doing. Certainly doesn't represent everything that the university is doing on the COVID-19 front. We have economists looking at the impact on the economy. We have folks looking at vulnerable populations, both in urban centers and in rural areas. We have sociologists looking at the impact on people where they live and where they work. We have engineers looking at different ways to design workspaces. So there's a ton of work going on at the university and a lot of things that we know public policymakers are considering. So this represents one sliver of the work we're doing, one sliver of the consideration that public policymakers are taking into account. Not to minimize it at all, because it's certainly an important piece of it, but we recognize it's not the whole pie, it's part of the pie. I'd like to ask you to throw your questions into the chat box, and we'll take them in the order that we receive them. That's not to be overly controlling, and if somebody needs to speak up, that's fine. I'm not trying to regulate people. We're just trying to organize this so that it happens in a way that's coherent and functional for everyone. So with that, again, my name's Jay Thorne. You can feel free to follow up with me, with Joe Kaspermeyer, or with Skip Dara afterwards. We'll be happy to help you out. And this is the beginning of what we expect to be a weekly opportunity for our experts to comment on the data collection that we're doing and help interpret that for you. But also, I know part of what Josh will do today is try to help explain to you how to read some of these charts so that you feel a little more comfortable doing that on your own. But we will be doing this weekly. We may bring in some additional experts along the way to provide clarity on specific issues. But that's the run of show for today. And with that, I will again ask you to please mute yourself. I will do likewise and turn this over to you, Josh.
Hello, everyone. So I'm Josh LeBaire. If you don't know me, just very briefly, I'm the executive director of the Biodesign Institute here at ASU. My background in brief, I'm a medical oncologist by training, did an MD, PhD. My research primarily has been in diagnostics, and certainly over the years, I've done a lot of diagnostics research on infectious disease. Typically, we do a lot of high throughput research studies, and a big focus has been, frankly, on serology, although that's not what we're doing at the moment with respect to this. So let me just very briefly mention that, as Jay pointed out, there's a lot of research going on, even in the biological space here at Biodesign. Got folks thinking about how to do point-of-care tests based on using paper as a readout for the virus. We have folks, my own lab is looking at not only doing serology studies, but specifically serology, not just on this coronavirus, but on all known human coronaviruses. One of the questions I think that a lot of physicians are interested in understanding is, does prior exposure to one of the less virulent strains of coronavirus in some way protect individuals or reduce the response they have to this coronavirus, or vice versa? Does prior exposure in some way increase the response? And so we're hoping to answer that question with some of the studies we're doing there. And then, of course, we've got a whole group of scientists here, Sean Chen, Brenda Hogue, Grant McFadden, Burke Jacobs, all of whom are working on different approaches towards developing vaccines. So the reason I'm talking to you today is a big part of what we're doing here at ASU is a more direct response to the virus for immediate management. This research is a COVID response team that I lead. Every morning, we meet with around 50 individuals from across the university to talk about how ASU is responding to the virus. And we are building what we believe is an end-to-end solution. This includes collecting samples, testing samples, tracking the data in a home-developed database, providing results to individuals about their status, and also working together with the county and the state in trying to engage in contact tracing regarding the testing. So, this began with the recognition that ASU hopes to bring all of its students back in the fall. That means that our numbers will increase to around 100,000 people, including both the students and the staff and everybody attached to that. And we want to keep that population safe. And so we wanted to have the capacity for that kind of testing. So we have built an automated testing platform, which we are expanding as we speak. And that testing platform is based on saliva. And we've gone that route because it is going to be much easier to collect samples from a population that size. So that's sort of the background. I know there's a lot of interest in talking a little bit about kind of where we stand in the state, because obviously things have been moving quickly in the state. What I'm going to do is I'm going to share my screen here in a moment, and I'm going to pull up the testing page, the COVID trends page that Biodesign has at our website. So at the very top of the page here, you'll see we have our clinical testing laboratory. Many of you have already seen this site, and we have a page called Critical COVID-19 Trends. And this is basically data that we put up daily. We're ever enhancing this site. In fact, we're going to do kind of a rebuild of the site on Friday this week to make it a little bit more cell phone compatible, mobile compatible. But this, on the top here, we have a number of sort of key statistics. What I'd like to do is bring you down to my favorite chart. So there are a lot of other charts here, and you're welcome to look at them all. This here is my favorite chart. And this chart is a little hard to read until someone walks you through it. It's called new cases versus total cases by state. What I'm going to do to simplify our view is I'm going to show that we can pick any states we want here. So I'm going to pick a few of them myself just for illustration purposes. So let's pick California. Let's pick Georgia. Let's pick Hawaii. I'm going to pick New Jersey. Some of these I'm picking because they illustrate different use cases, if you will. And then I'll pick Texas. We can go back and add more if anyone wants them, but for now, I think this is a good set. I can get up to here. Okay, so now that's a little bit easier graph to read. So what does this graph show? So the metaphor I'm going to use here when we talk about this graph is that of a car. And what we're really looking at, this graph to me is the speedometer for the car. This is telling us how things are moving and the rate at which they're changing. So what you have to remember is most graphs that you're used to looking at from left to right are dates. And this is not dates going from left to right. This is actually total cases going from left to right. And the other thing to remember here is that this is a logarithmic plot. So it goes from 1 to 10 to 100 to 1,000 and so on. On the y-axis is the number of new cases. So obviously, as new cases are appearing, that means that the virus is spreading. And so moving up is the direction we don't want to go on this graph, right? So if we go back to the speedometer on a car, let's think about the sort of three cases we could consider. The first case is we're putting the brakes on, we're slowing the car down, and moment by moment, the car is going slower and slower and slower. That is clearly the direction we all want to go. I'm going to show that if you look at the case of New York here over time, as you move your needle down, New York is going the right direction. Day over day, it is decelerating. There are fewer and fewer cases. Same is true for New Jersey. Fewer and fewer cases day over day. The second case is the car is moving at a constant velocity. That means that we're getting new cases every day, but day over day, it's roughly the same number of new cases every day. And if you look at Georgia, for example, here, they're kind of running flat. That means that they're getting new cases every day, but it's roughly the same. Now, you could argue that in the last couple of days here, there's a trend up, but you have to kind of watch a little bit longer to see if that trend will stick. If you look at Arizona, this is Arizona right here. You look at us back when the state closed down, you can see that the state was running kind of flat for a while. But obviously now the state is trending in a new direction, and that direction is up and to the right. Up and to the right is the direction you don't want to go. That is the foot on the accelerator. That is the car going faster and faster moment by moment. That means that day over day, there are an increasing number of cases. That is the virus actively spreading in the community, right? And so you can see a number of states are showing that trend. Here's Texas, it's moving up a little bit. Here's California, it's moving up, maybe not quite as steeply as we are. An interesting case in point is Hawaii, which actually had they had come to a full stop down here. They had stopped getting new cases, but in the last little bit here, you can see that they're rising. One other point that's important to make here is the level of speed. So even when a state is running flat, right, it depends on at what rate. Obviously, running flat at 1,000 new cases a day is not the same thing as 100 new cases a day or 10 new cases a day, right? This is the car going really fast. This is the car going not quite so fast, even if it's a constant velocity. So I look at this chart every day, and this is kind of how I get a sense of what the trends are, for example, in the state of Arizona relative to other states. And you can see that right now, for the last couple of weeks, we have been in an upward trend here, not the direction we'd like to be going if we could avoid it. It is also useful to look, we also have a chart here that lets you track the counties in the state. So you can click that off. I'm going to pick a few counties just to make it a little bit easier to read. Here's Coconino. Let's pick Maricopa, Pino. Let's go down to Yuma. Again, you can look at any one graph. So here are some of the counties in the state. You can see, for example, Apache, which had been rising quite a bit, and there's been a lot of activity up there, has now flattened out a bit. It's not running as fast as some of the other states are. Same is true for Coconino County. That's also running kind of flat. But then if you look here at, Pinal County, certainly Maricopa County, and also Pima County, they're all taking off. Not surprisingly, those are counties that have high populations. Probably, the density of the population is what's allowing the virus to spread from person to person. So that's just, kind of a look at the kind of graph that I like to look at. Gives me, as I say, it's kind of the graphical equivalent of a speedometer for me to get a sense of whether things are accelerating, whether they're going at constant speed, or whether they're decelerating, which is the direction, obviously, we'd like everything to be going. We also have metrics on hospitalizations, inpatients, and so on. Some of that's also available at the state website. And then this is information on the current testing. And in black are the positive tests, in gray are the negative tests, and they refer back to these numbers on the left of the graph here, and on the axis on the right, the percent positive tests is indicated by the line chart here. For some reason, the negative test did not get reported on that date, and so it I think aberrantly reports every test as being positive. All right, so that's pretty much what I wanted to say about the things on our website. Some of you may have looked at other places on the website, and of course, you're welcome to ask questions there. I'm going to switch over now to some of the work that some of our other team members have been doing. I'm going to pull this up. All right, so we have a number of epidemiologists here. Let me see if I can get this to go. All right, we have a number of epidemiologists here at the university. Esma Gell is one of the faculty members in that field. Megan Jen is also an epidemiologist and a Molduzuk student. Heather Ross is a faculty member, and Tim Lant is a scientist who has been studying pandemics for years in his work. And this group here meets on a regular basis, and they've done a lot of modeling. Some of this has been talked about before already. I just want to remind you what we mean by a model. A model is really a mathematical way of answering the question about what we can see and what is actually out there. So obviously we can't test everybody. We're only testing a fraction of people in the population. And so we have to figure out a way to extrapolate from that number of tests, that is to say from the tip of the iceberg, to try to understand what the whole iceberg actually looks like. The other limitation we have is the tests we do right now are reflecting things that happened in the past. Sometimes the test result doesn't come out for days after the sample is collected, and that in turn reflects an infection that may have occurred a week before that. Remember that people get infected with this virus and it takes anywhere between 3 to 5 days for them to start producing virus, in their mucosal membranes, and they may not yet get symptoms for another 2 days. So they may be spreading the virus before they even get their first symptoms. And so it could have been anywhere from 5 to 7 days since their exposure. So when we look at data, we have to remember that those data reflect things that happened in the past. And so the idea behind a mathematical model is, how do we understand all of what's actually going on right now? And can we use that to predict the future? And so the models are based on what we know about how infectious diseases behave. They're based on what we know about specifically the behavior of this disease. And they are based on a variety of available data. We use these models to make inferences about the past so we can try to get a sense of, how was this spreading a week ago or 2 weeks ago? It helps us understand the present, so we understand how broadly spread the virus is in the community right now. And if the trends in the model continue, what would happen? And we can also do things with the model, like we can make adjustments to the model and ask what would happen if, for example, if transmission were to increase, what would happen? If we were to bring transmission rates down, what would happen? Okay, so this gives you a sense of what the modeling is meant to do. I will mention that the model is now published online at this site here. So you can go here and actually read in much more detail what the model shows. I'm going to just show a few highlights from the model. The first highlight I'm going to show is what we know about the transmission rate. And in this graph, the x-axis is dates. So you are looking at dates going across here, and then you're looking at numbers of individuals who are testing positive. The team that built this model, they did what's called backcasting. They basically said, okay, if the tests are positive today, what does that tell us about the past when these people were likely to be infected? So that's what this is. They calculate a number called beta, and beta is, if in effect, a measure of transmission rate. And what that means is it's based on, first of all, the number of times people come in contact with each other. That's part of it. And the second part is, what's the likelihood, if they come in contact with each other, that they're transmitting the virus, right? So those two factors combined leads to a beta. And what you can see is that, when things started opening up in the state, if you backcast on our data, that the model predicts that there has been a rise in the transmission rate. And that rise is about a 40% increase in transmission. That's obviously what we don't want to see. We don't want to see increased transmission, but that's clearly what's happening. And that's borne out based on the data. And I will also mention there is this factor called the X factor, 1.67x, and also 4x. What that means is when they develop the model, and I'll show you this in a slide coming up, the expectation is that the testing we do is only testing a fraction of the population. How many of the people that we see as positives in the testing, how many more out there are there that we're not seeing because those people are not getting tested, right? So, and that's what's shown on this graph here. So you can see that here is the 1.67x line. This line is assuming that there's another 67% of folks out there that are positive that we're not seeing. 4x means that 4 times the number of what we're seeing is what's out there, and 6x would be 6x. We don't think the model fit very well for 6x. Historically, the earlier model built by this group suggested it was about 4x. Currently now, they think it's trending closer to 1.67x as we're doing more testing. The black line with the diamonds on it, that's sort of the best estimate interpolated graph for what the model shows as the expectation of what's really going out. That is to say, that's our current picture of the entire iceberg. And then what you see in the little red X's is the actual data that they're tracking. So this is what I was going to mention. This is sort of showing what we think is the projected number of infectious persons out there. Again, in the red dots are the actual data, and you can see that they are starting to kind of increase. We think that what's reflected is this black line here. Back in early May and late April, when the testing was much less than it is now, we think that there was probably 4x the number of people out there. There we go. I'm going to pick that. But we think now with the increased amount of testing, this line is migrating over here to the 1.67x line. And so hence this line is headed this direction. So obviously, it is certainly true that the more testing you do, the more cases you're going to see. But obviously, the number of cases we're seeing is going up faster than just that. The number of cases we're seeing is a reflection of increased transmission of the virus and more spread of the disease through the community. Okay, so I think that's it. These are the folks that built that model. Particularly want to draw your attention to Esma Gell and Tim Lant, who are key, and then Anna Muldoon is the graduate student that did a lot of the hardcore number crunching. So I will stop there, and maybe we can switch over to questions.
So I just unmuted everyone. Joe Kasper-Meyer's dropped a couple things in the chat box for you to link to if you wish, but the floor is open.
I was wondering, Doctor, if you would go back to the hospitalizations graph and walk through Arizona's numbers.
Okay, yep. Let me pull that up. So that was on our website, right? Yeah.
Yes.
So, right. So this is kind of a summary graph for hospitalizations. By the way, you can increase this to any amount of days you want. You want to see the trend. So yeah, here are the numbers, and clearly there are an increasing number of hospitalizations in the state for COVID-19. There's no doubt about it. And if you talk to people in the hospitals, they'll tell you the same thing. I'm sure you folks have heard this from talking to them yourselves. Both that and the number of patients in the emergency department are going up. And I think that these numbers represent all-time highs. So certainly there's no doubt. I mean, there are increasing number of people in the hospitals.
Would you do hospital capacity as well, please?
Okay, so we are adding those graphs probably on Friday. I'm going to switch to the state for that. And the graphs that we're going to be doing, yeah. So here's what the state is posted here. So that's ICU beds. Let's do inpatient beds. So this is inpatient beds that are currently used. Now, I believe the numbers in this graph are all inpatient beds. They are not COVID-19 specific inpatient beds. And this shows you the availability. If you want to see just COVID-19 beds, they are here, but that's not shown across from the availability. We are, I think, as I say, on Friday, we're going to post a chart that kind of combines them all together that shows COVID-19, non-COVID-19, and then availability on the same graph. So if you were to look here and you were to plot COVID-19, it would probably be somewhere where my mouse is. So the majority of beds in the hospitals right now are not COVID-19 beds, but the number of COVID-19 beds are definitely going up.
Thank you.
It's Graham Resnick here. Thank you very much for doing this. A few questions. One on hospitalizations, looking at the paper you put on the screen earlier. Can you give us an idea of how you project the number of hospitalizations to proceed to rise without any interventions? And what kind of interventions, non-pharmaceutical interventions, do you think could be taken to limit the number of hospitalizations?
Right. That's a very good question and an important one. So let me go back here. This guy.
Again, I just want to say, if you've got noise in your background, please mute yourself.
Right, so let me escape here for a second. And, oh, okay, hold on. I need to just change one thing in this. There's a slide. I have a slide here that I want to open up. Okay, unhide that slide. Yeah. Okay, this is a plot of hospitalizations. The actual data are shown here with these red X's. The black line again is our best interpolated graph, and I have to be honest, I don't think that this interpolated graph fits the data as well as I'd like it to. Yeah, can you hear me? This here, the line in gold is capacity available for COVID-19, and this black line up here is total capacity for hospitalization. Okay, so you know, if we really do hit, let's say, this line here, the 1.67x line, then we are going to start, you know, out in the end of July, start threatening hospital beds. The question is whether or not our hospitalization curve here fits as well as I'd like it to. I'm not convinced that it fits that curve that well. It may take longer for us to start threatening total hospitalization capacity at this point. Now, to answer your second question, which I think is the most important one, is what can we be doing? And I think there are two key elements here. The first is, when we go out, we need to be safe. In public, people should be wearing masks. What we know is almost certainly the best way this virus is transmitted is through speech. People, when they talk, are producing droplets. In fact, we produce 2,600 droplets per second when we talk. And that's talking at a normal voice. That's not singing or projecting in a loud voice. So we're producing a lot of saliva in the air that fills a cloud around us that then infects other people. Now, obviously, if we're wearing a mask when we talk and the person we're talking with is wearing a mask, the likelihood of transmission drops precipitously. We know masks are incredibly successful at blocking transmission. So if people, when they are out and about in public, are wearing masks all the time, they're going to reduce transmission significantly. So that is certainly one way in which we can significantly limit the transmission of the virus. The other is we need to be very actively testing people and tracing people so that we can identify wherever there are pockets of virus and get people isolated until they pass through the illness, and so that they're not transmitting the illness. I mean, you know, it's not the best metaphor in the world, but one metaphor here is that this virus is very much like a fire in a community. The difference is that in a fire, you can put the fire out with water. Imagine if there were a fire in the community, but there was no water to put it out because there's no way to just stop transmission. The only way you can stop transmission is separating out anything that's burning from everything around it until it can no longer light anything else on fire. And so the better we can find wherever there are pockets of fire and pretty much get them separated until it burns out on its own, the better we can prevent spread. And so more testing and then more tracing so we can identify whoever may have it is certainly going to help us.
Can I just follow up on something you said there regarding, you said the slope or the curve of the diamond graph is not what you'd like it to be. What do you mean by that? And what exactly is the COVID capacity? Because that's a relatively new, we haven't seen that referred to by DHS, a specific COVID capacity.
Yeah, I think that our epidemiology group basically assumed that there would always be this demand for regular hospitalizations, and then they just said this is what's left over after those beds are occupied for regular things. Because you're right. I am not, one of the reasons I didn't show this graph to begin with is because I don't think that our numbers are as solid here. I will be honest. When I say that I don't like this curve, it's because this curve was really meant to fit for the number of cases. It was not meant to fit for hospitalizations. They fit the infectious cases first, and then they just made estimates based on hospitalizations. And if I look at the red dotted line here and I look at the slope of that line, I do not see where it starts to turn up like this. So I would extrapolate that line and say it's going to head out in this direction. So I would take this particular graph with a grain of salt, recognizing that all models have flaws, no models are perfect, and we're still developing this information.
Hi, this is Jeremy Duda at the Arizona Mirror. I was wondering if you guys have models for various other scenarios, like what things look like if there's a mask mandate or another shutdown or other kinds of policies that would potentially curb the spread.
Yeah, so that's a really good question. And that gets at something that that I mentioned back here, which is that you have to remember that real world interventions are not the same as hypothetical interventions. What you can do in a mathematics world is you can say, what would happen if I were to decrease transmission rates? In other words, change the number that everyone refers to as beta. I can't say how changing, mask wearing changes beta. We don't know that. All we know is that if we wear masks, we are likely to reduce beta. We just don't know how much mathematically, because that has never been measured as far as I know. So we can say that if we were to bring that, if we can get back to, from the increase in 40% in transmission back down to where we were, that, what the curve would look like then mathematically, and it would look obviously a lot better than it does at the moment. But we can't exactly say what specifically mask would do, or hand washing would do, or, keeping social isolation would do. Those are harder things to measure. There are people out there working on that. We do know that by far, probably the most important thing we can do is mask wearing, because that is the way we transmit this virus, is by talking mostly.
So a close cousin of that question is in our chat box. It says on Friday, CDC's Jay Butler suggested the increase in Arizona case numbers resulted from, I think there's a word left out, I think he means from increased testing. Does that strike you as a reasonable explanation?
Yeah, I don't think that our increased numbers reflect only increased testing. Certainly, the more you test, the more you're going to uncover wherever there are embers of fire. You're going to find it more by looking for it. But the fire's there, and there's no doubt about it. You can tell by the numbers in the hospitalizations. You can tell by the number of emergency room visits. There are more cases of COVID-19 in the state, and there is more transmission out there. And if you talk to the doctors in the hospitals, they'll tell you the same thing. So it's not just increased testing, although certainly the increased testing will help us find those cases. And my hope would be that by finding them, we can get people isolated and prevent the spread.
So another question in the chat box, what is the difference between beta and RO?
Right, they are different mathematical models. RO is a different way to look at it. That's kind of asking, or really what we talk about once the RO is measured at the beginning, and that's inherent to the virus and its behavior. What we're really talking about is R effective, and we think that Arizona is somewhere in the range of 1.2 at the moment. That's the best estimates for that. Whereas beta is really meant for the kind of model that our team uses, which is called an SEIRD model. It's a compartmental model that looks at different compartments of individuals, people who are infected but not symptomatic, people who are infected and symptomatic, so on and so forth. So they measure slightly different things.
Other questions?
Are we seeing deaths increase as new cases increase? Is there any correlation there? Is the mortality rate staying the same? Or?
Well, the mortality is a percentage of cases, whereas, but we are seeing there are increased deaths for sure. I think that's just a result of because there are more cases. But I think this is the no, this is not. We don't have it on our graph. I think it's in the state graph. Let's find the mortality. Here's the COVID-19 deaths. Right. So obviously, the death number is going to be trailing where we are because people don't die instantly when they get it. So right now, what we're seeing is increased number of cases, and it's going to take potentially weeks before those people that are going to have bad outcomes lead to those bad outcomes. So I think we're going to have to kind of watch those numbers, but you can see the overall trend up until mid-May was an increased number of death rates. And I think that some of these folks here may follow. It just depends. It also depends on how well the doctors can manage these cases. So if they get better at managing them, then hopefully we can reduce that death rate.
Bram Resnick with another question regarding the report that you just released. And I want to read from it. It says, even without considering any negative effects of exceeding hospital care capacity, and then in parentheses, which is likely to happen without the initiation and widespread adoption of non-pharmaceutical interventions. Again, going back to what you said a minute ago about not feeling solid about those projections, saying that exceeding hospital care capacity is likely to happen seems like a fairly solid statement. Do you agree with that statement?
I am not as confident that we, certainly if obviously if we continue for many months at this increased rate, yes, that's going to happen. I would not, I personally don't think that we have enough evidence right now to say that that's imminent.
So another question in the chat box. Some are reporting that Arizona is now one of the hardest hit areas on the planet, surpassing Brazil, Peru, and all European countries in cases per capita, and that Arizona is likely to pass the worst case peaks of the entire pandemic, including New York's and Madrid's. Does your data support that conclusion?
I don't think we can say that yet. First of all, places like New York were overwhelmed in cases to the point where they could no longer manage them in their available capacity. We don't have evidence yet that our capacity is threatened, at least not imminently. Obviously, if our trends continue to accelerate, that we have to re-examine that. But right now, there are still beds available. There are still ICU beds available. So I don't think we can say that we are threatened in the way that places like Italy were or New York was, where they couldn't, where doctors had to make decisions about who got, ventilators, for example. So, certainly we are rising faster than I'd like to see us rise, but I don't think that I would compare us yet to New York or some of those other places.
Can you even speculate in terms of a timeline as you look at our current rise? Do the numbers give you some kind, are we talking end of summer, end of July? Is there a way to build that and model that out and see if we stay at the current rate when we will hit our capacity? You could look at those models and you could plot them out, but there are some caveats here. And the biggest caveat here is that what we're looking at, let me put that back up again. So here's, these data here I feel much more confident about. The problem that you're dealing with is that you're looking at an exponential curve, and all it takes is a little bit of an error to make a huge difference in an exponential curve, right? Because exponential curves are, 1 to 2, 2 to 4, 4 to 8, 8 to 16. They go up very fast, and as soon as you get out even a little bit, the numbers change dramatically. So the farther out we go, the less predictive the model becomes. Just the same way that, we're pretty confident about predicting the weather in the next 3 days. It's a lot harder for us to predict the weather a month from now. Same kind of thing applies here. And so I would say we're obviously moving faster than we'd like to be. That would be my interpretation. But whether I could say that we're going to start hitting hospital capacity in August or September, I wouldn't feel confident making those predictions. What I would do is want to keep monitoring where we stand frequently, and I would want to be actively working on non-pharmaceutical interventions to start to decrease the trend. We do not want to be headed in that upright direction on the speedometer that I showed you at the beginning. We want to be going flat, and eventually we want to specifically be going down. We want to decrease the number of cases. Thank you.
A couple more questions, if I can. A, have you shared all these findings with DHS or the governor's office? And B, picking up on your metaphor that we have hit the accelerator on cases, given that, how urgent is the need for non-pharmaceutical interventions, like perhaps requiring masking in public places?
So yes, our team met with the group at Department of Health Services last week and showed them the new model. So that we are actively talking to the state all the time. They are both seeking our advice and they are openly listening to it. I certainly would strongly urge folks in the state to wear masks in public in particular. That is where spread can happen, because obviously we don't know those individuals, and they'll never have a way of contacting you if they if they turn out to be positive, to tell you that they were positive. So when you're out in public, when you're talking to people, even at the workplace here at Biodesign, and at ASU in general, President Crow has instituted a mandatory mask policy in all our buildings, and I support that wholeheartedly. Right now, I'm alone in my office, so I'm not wearing one, but when I walk out of this office, I put my mask on. I think we should all be doing that. It is right now the best thing we can do to slow the spread of this virus and to prevent it from traveling from person to person.
Doctor, one more, I swear. Have you ever seen an event or a situation that we're in where the numbers are being read so differently on a spectrum? We have one guy saying the numbers say Arizona has passed the Rubicon. And then at the other end, you have another official saying everything's great, everything's fine, we're in control. Is this unusual, or are events like this, is everything always looking at numbers and saying, we're fine, oh my God, the sky is falling?
Well, yeah, I mean, I think when people get nervous, you get different interpretations. I'm certainly not here saying that I think the sky is falling. I wouldn't take that position. I would also say that we're not where we ought to be. Where I believe we are is that we are seeing an acceleration in new cases, and I would like to do everything I can to stop that, because we are dealing with something that transmits exponentially, and if it gets out ahead of us before we can stop it, then it will spread even more, and we want to stop that.
What do you make of Governor Ducey's comments from last week that the most important number we should be looking at, the most important data point, is hospital capacity?
Well, Governor Ducey has a very different position than I do, and I don't envy him his job at all. He's weighing other considerations on a broader scale. I'm really here as a scientist, sort of telling you what I think about the infection rate, the transmission rate, and the need to kind of get those under control. Obviously, we care about hospital capacity; that's key. But there are a lot of considerations in the context of a pandemic like this.
So Vaughn Hilliard, if I could ask, so in your mind, then what went wrong there? Quite frankly,
you're asking why is the transmission rate going up?
Yeah.
And I think that certainly as things opened up, I think a lot of folks may not have fully understood, or maybe not paid as much attention as they ought to all the practices that we should continue to do as we open up. So, I don't know about you, but when I go out on the weekend and I go into stores and I see a lot of people walking around without masks, or I see people sitting in, not long ago I passed a soccer game. A lot of parents, I saw clusters of 10 people chatting without masks while kids were playing soccer, as if, there's no pandemic going on. And I think we just got to remind folks that this virus doesn't care. This virus is just a virus. It's going to hit anyone it can hit. And we are all fuel for its fire. And it will spread if we are not careful about keeping things separated and keeping our, keep the transmission down. So we've got to hopefully all pay a lot of attention to that.
So with that, folks, I've got to let Dr. LeBaire get back to the work that allows him to share smart thoughts as he has this morning. And so you can reach out to me. You can reach out to Joe Kaspermeyer. Be glad to follow up with you. But
you said you do this weekly. Are we going to do it every Wednesday?
That is the plan.
Every Wednesday.
Yes, every Wednesday. And it's in all of our interest to kind of set into a regular time. I can't promise that because I haven't looked a week ahead, but that's our goal. Yes.
Excellent. Great interview. Thank you so much, Dr. LeBaire.
Thanks
for the information.
Thank you.
Great.
Appreciate your attendance. Have a good one.
Thanks, Jay.
Thanks, Jay.
thank you.
Bye-bye.
Thank you, Josh.
Thanks. All right. Take care, Jay.